Testing 1 2 1 2. Test test 1 2 3. Test 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 1 2 1 2. Good.
All right, yeah, I think Dr. Farsi right here. And then we have the screen will be ready when time comes. Okay, good. Well, good afternoon. We're so grateful to be here at Miami-Dade College at North Campus. We appreciate all the great work that you're doing. Just got to see some of the folks from the law enforcement program. They're going to be going into different agencies. You know, I didn't have the but if they wait just a little longer and a law enforcement bill goes through the legislature, they'll get a $5,000 signing bonus whenever they show up at one of the agencies. But we do appreciate their willingness to be involved in public service. As you know, a day, 2 days ago, the Biden administration abruptly canceled the ability to use two of the most prominent monoclonal antibody treatments that Florida has used a lot to fight COVID-19. We had thousands of Floridians that had appointments scheduled for yesterday and today and tomorrow, and they were told that those appointments could no longer be honored because the medication was no longer allowed to be administered in the United States. And this was a rash decision. This was not something that we got any real advance notice for. And it's a decision that I think is bad for patients. It's not keeping with the way you do clinical data. And we're going to be able to hear from some different folks today. So joining me today is Dr. Ken Shepke, who handles health for the Division of Emergency Management. We have Dr. David Farsi, who's the chair of the Department of Emergency Medicine at Mount Sinai Medical Center. Dr. Dwight Reynolds, medical director for Centers for Health Promotion. Scott Fortney, realtor and monoclonal antibody recipient. And then via Zoom, Nancy and Frank Schlaller, who tested positive for COVID, and they actually had an appointment for monoclonals yesterday that was canceled by the Biden administration's decision. So it's important to talk about, the facts here. And of course, over the summer, when we started to see people get hospitalized in large numbers for Delta, very few people even knew that there was treatment available. We worked hard to set up a lot of sites. We helped tens of thousands of people stay out of the hospital, save thousands of lives by providing that treatment. And obviously it had positive impacts, because if you look from the time those sites got up and running, you saw a huge decline in hospitalizations in Florida. And if you look from maybe the beginning of October, when that program had already had the effects filtered through till now, we have one of the lower COVID mortality rates from October now as a result, we think, of the early treatment in part. And so that's just the reality. Now we get into Omicron, and you see huge numbers of cases, but fortunately, a much lower percentage of hospital admissions and deaths. We, though, believe that people want to be able to access treatment. And so there have been concerns about how effective some of the monoclonals would be against Omicron. And obviously, as these variants change, that's something that's clearly the vaccinations are not preventing infection against Omicron the way they were touted with some of the other variants. And so that was something that was known. But our view was, first of all, you don't know when somebody comes in necessarily whether they have the Omicron infection or the Delta infection. And we know definitively this stuff is great against the Delta variant. And so why would you take that out of play for somebody that's saying it's not good with Omicron? Everyone's got to acknowledge it is good for Delta. And the CDC will say, well, there's no more Delta in some of these parts. And look, obviously in Florida, we believe most of it is Omicron for sure. But you have no way of knowing exactly, what percentage is Delta. And the CDC's been wrong about that. I mean, they said a month ago that it was 75%. Then they had to backtrack, say, oh, it's actually 25%. So their modeling is not something I think you would necessarily hang your hat on. So our view is this should be an option for people, particularly because when you're talking about high-risk patients, you're not going to necessarily know if they go in for early treatment. Yeah, as it progresses to where the monoclonals wouldn't work anyways, if it's deep in the lungs and you do see some symptoms with Delta that would be a little bit different than Omicron, clearly maybe a clinician would be able at that point. But initially with the positive test and the onset of symptoms, which is when the treatment's most effective, you wouldn't necessarily know. So just that alone makes the decision really unbelievable that you would take it away knowing that these other variants are not 100% gone. Delta's not 100% gone. Also the fact that the study that they did was not a clinical trial. It was not even done on human beings. It was a lab study in vitro, and they basically said that it was not effective, dealing with it in a lab environment. And look, as this thing goes, you conduct trials with human beings participating. Maybe it will be the case that it is not effective, although I think we're going to hear evidence that it has had some positive effect in Florida, and we believe that with people that have gotten it. But man, that is not a significant amount of data to just take it off the market. I think what you would say is, you could say, hey, here's a lab study that's been done, and then let individual patients make those decisions. Let doctors make those decisions about, given what you know about that lab study, is that enough to say, we don't want to do this if somebody comes in who's high risk and COVID positive. Our view in Florida is that we want doctors to be able to have the ability to administer this. We want patients to have the ability to access it, and then they can make the decision what's best for them. By all means, if it's not something you want to do, you make your own decision, talk with people, and go from there. but to not give anyone the ability to do this at all, is really, really a significant problem. And then to do it so abruptly with no notice. I mean, they have this available. I mean, what they could have said is anyone that's got appointments for the next 5 days can be honored, or they could say maybe 2 weeks from now. I mean, I still wouldn't have liked that. But man, to leave people hanging the way they have is really, really problematic. And so, we're very much opposed to the way that particularly the thousands of Floridians who were in the system waiting to get treatment, to them wake up to an email saying that these treatments are now prohibited and tough luck, go take an aspirin. That's just fundamentally wrong. That is not the way you treat people in this country. And so we want them to be able to access it. They can take a look at these studies and make their own decisions. And if you believe you have Omicron and you don't believe it'll be helpful, then that's fine. But I think that many people would like to have that option, particularly our elderly population. So we want to make sure that that's the case. But I think it's important just to point out, because you have state-run media outlets effectively that will parrot the talking points of the regime. It has not been proven that this does not work against Omicron. It is all based on that one lab study. Now, time will tell. If you do clinical trials, who knows how it'll end up working out. I don't know. I wish I did know. But when that is being said like that, that is not accurate, and that's misleading people. And so we have, throughout this Omicron wave, which clearly is going down pretty significantly, and which is the way it has done in South Africa and in Europe, and so this is what we expected. But we have been talking to clinicians throughout this whole time, saying, okay, we do have this. How effective is it? And by and large, they've had positive results. Not saying everyone says it's 100% in any way. It may very well be less, but it has provided some support for people, and it has helped some people have symptoms resolve. That's been the experience in the state of Florida. And so we're happy to be able to be here with some folks who are going to provide some input. So I'm going to let Ken Shepke, Ken was really one of the architects of the summer when we set up those sites. We were cranking to where we were knocking out 5,000 treatments a day just at the state sites, in addition to what was being done in the medical system, and really, really made a difference for a lot of people. And I'll tell you, not only the fact that Floridians were able to access it, something else that I think was that I've noticed, I'll have people come up to me saying, oh, Governor, thanks for the monoclonals. I was like, well, where'd you go to get it? They're like, no, I didn't get it in Florida. I'm like, well, why are you thanking me? And they're like, because I saw your press conferences. I didn't know anything about that there were treatments for COVID. My husband and I got it. We're in our 70s, and we're in this state, and we asked all the physicians. We wanted it. We got it. And we got better very quickly. And so not only did we set up an infrastructure, we really put this more on the map of, you got to look at this not just through the lens of one thing or another, but really have to look at it holistically. Final point before I kick it over to Dr. Shepke is just this. When you're talking about the variants and how much is Omicron, how much is not, just keep in mind, I mean, here in South Florida, no one needs to tell y'all, we have people coming from everywhere here. So maybe there's not as much Delta in kind of our native communities who are Florida residents, but we have so many people cycling in and out. Who's to say that they're not also bringing different Delta? That could absolutely be the case. And so we don't know when someone comes in one way or another. And we are also in a unique environment in Florida where our domestic tourism is stronger than it was prior to COVID. You look at restaurant reservations and compare January 22 to 2019 pre-COVID, Miami's up 15%. A lot of these other places that have draconian measures, they're down 50, 60%. In reservations. And so you just see there's a difference. There's energy here. There's people that want to come. Well, you have to factor that in when you're looking at it. We're not a static environment here. We're a very dynamic environment. And to just say that there's no Delta here, I think that's a very difficult thing to actually prove when you're doing it. That said, Dr. Shepke.
Thank you, Governor. And I appreciate that the governor's efforts on treatment. All diseases in the field of medicine are treated with two prongs, one on prevention, which I think we've been very strong on, You all recall we put out the vaccinations for long-term care facilities and the older folks, and that's a great prevention strategy. But even with the vaccines, we know some people get sick. So what's been missing until Florida really became a national leader in therapeutics is the treatment side, which we do, again, for all diseases, prevention and treatment. And the treatment is very, very important. And we're going to continue to see this virus roll out in various mutations, various variants are going to come to us. And one of the things that's been lacking until Florida really became a national leader in this is treatment. The monoclonal antibodies, it's really been at the forefront of that treatment. It's a very, very well tolerated, scientifically proven treatment against the virus. And what's important, it's safe. There's very few side effects. Just about every person who meets emergency use authorization is a candidate for that. And what's nice is we are seeing in the pipeline some other various treatments that are coming through, but they have various problems with them. They require much more complex medical decision-making. They have drug-drug interactions. There's some laboratory tests you have to get for them. So the value of monoclonals cannot be understated in the ability to treat people who have this disease. Now, the study that the governor talked about that's being referenced is a study on cells. When a medication is approved to be used on humans, they might start off on cells to make a theory on whether it will work on humans, but then ultimately you test it on humans to see whether it works or not. So similarly, if we're going to assume that a medication stops working based on studies on cells, I think it would be valuable to see that on a study on humans as well. And the reason why that's so important, which I think you're about to hear, is we've got two pieces of conflicting data. We have this study on cells that suggests maybe it might be less effective on Omicron, these particular monoclonals. But then we have real-world experience in humans where we see really excellent outcomes. And those two pieces of data conflict. And rather than saying, well, then let's just stop doing it, I think we need a third piece of data as the tiebreaker, which is let's do a formal study on humans to see if it works or not. And as the government reported, maybe it will, maybe it won't work on humans, but I think that's been a missing data piece. And I think the Floridians and really the rest of the nation have come to expect the availability of these treatments. So it's really important for us as physicians who are at the bedside taking care of the patients to have those tools at our disposal to make those decisions for the individual patients what treatment is best. Thank you, Governor.
Great. And I would also just point out, we were the first state. So the FDA revoked for Regeneron and for Bamlanivimab, which is the Eli Lilly monoclonal. And we had been doing those in the summer. But what we also did, we were the first state to try to use the Sotrovimab, which was done by GlaxoSmithKline. And actually, the VIR technology, whatever, the person that did this one study is actually affiliated with Sotrovimab. And I'm not saying it doesn't mean, but I mean, you know, you're knocking out your competitors here. No one's really talking about that, but it's right there in the disclosures. So we embraced the Sotrovimab when that got EUA in the late spring of 2021. When the federal government cut our monoclonal allotments in September of 2021, we did a deal, the state of Florida, with the GlaxoSmithKline. We got Sotrovimab to help plug in some of the holes that we had. And unfortunately, the Delta wave crashed enough to where we had very low incidence for many weeks and months. And even with the very low allotment that the Biden administration was giving us, we were still able to meet the basic demand. But, you know, the federal government's had 6, 7, 8 months to stockpile this Sotrovimab, and they didn't do it. So they're kicking out the competitors from the market. They're not allowing them to be offered. And so you have Sotrovimab, and we're happy to offer that, but there's not nearly enough of it. And this is not something that is just all of a sudden new. I mean, they had a lot of time to be able to prepare and arrange for this, and they haven't. And so, okay, you haven't prepared on the Sotrovimab, so then why not let folks use some of these other treatments? And so that's, I think, one of the reasons that's so frustrating. It's one thing if you're putting off the Eli Lilly and the Regeneron off to the side, but then you're saying, here, we're gonna backfill you with the Sotrovimab. You know, we would do that. It's a little bit more, I mean, it's an IV versus the subcutaneous injections, but that's fine. We would have done it. Our sites would have done it, and we would have been happy with that. But that's not what's happening. There's just much less options for patients. And that can't be the right answer. Okay, Dr. Farsi, why don't you tell them kind of, about your background and then what results you guys have seen over this Omicron wave with the monoclonals?
Thank you very much, Governor. Thank you very much, Dr. Chepsky. Dr. Farsi, been part of the COVID task force since the beginning, and we've been studying monoclonal for over a year and a half. We've published already 3 papers. I have non-disclosure, no financial benefit from any companies or stocks, just saying this in case if anybody thinks I might. But we've been studying the monoclonal to see if it actually does what it says. We've published the first paper saying that it was an amazing, during the Delta wave, reduction of admission. And what you remember with COVID, we're not trying to overwhelm the healthcare system to prevent crashing the healthcare system. So any admission we can prevent is underburdening the system. So we looked at it and we studied this. When the first paper came out that Dr. Chepsky talked about, looking at the test tube, saying that sotrovimab does not work on Omicron, this is based on a test tube. We, at our center, decided to say we are going to use Regeneron because that was the only monoclonal we had at the time, and we had a very large stock. In the course of 6 weeks, we had 1,000 patients, and this is roughly estimate. Our paper is currently being finalized, but 1,000 patients that received monoclonal. Out of the 1,000 patients, and they're considered high risk with 3 factors to receive it: comorbidity, weight, diabetes, hypertension, or something, at least 3 factors. And we only had a single digit of patients that came back and needed to come back to be admitted, less than 5%. When you compare to the group of patients that we treated and we saw, right, we saw a very large amount of patients with vaccination, without vaccination, on average, 10 to 15% of patients who visited any of our centers had to be admitted to the hospital. So you got COVID, vaccinated or not vaccinated, 10 to 15% required admission versus less than 5% of those patients who receive monoclonal. Again, like Dr. Chepsky said and the governor says, we're not here to say that one is better than the other. We need what's called prospective data, meaning we need data to be studied forward. And we are ongoing, my director of research is in the room, and we're ongoing, trials ongoing, and result will be telling us the story. Thank you very much, Governor.
Great. All right. Thank you. Okay, Dr. Reynolds, can you introduce yourself and then
Sure.
talk about some of the things you all been doing?
Sure. Thank you, Governor DeSantis. Nice meeting you. And, of course, Dr. Shefke. My name is Dr. Dwight Reynolds. I'm a board-certified emergency medicine physician. Been so since 1985. Been a physician since 1978. I recall taking the Hippocratic Oath, as my colleagues did too, I'm sure, when they became doctors. Me, again, it was April 17th, 1978. Hippocratic Oath, there's one point that stands out to me in this discussion, and that is, above all else, do no further harm. My point is pretty simple, guys. If the patient has potential of benefiting from what I'm doing, then my God, I have the right to do that. I was pretty upset. I don't usually get upset very often, but I was pretty upset. I think it had to be around 8 o'clock in the evening on the 24th, a few days ago, to wake up to find out that the FDA had pulled the EUA for 2 of the medications I use mostly for my COVID-19 patients, whether they've had a post-exposure issue or they have COVID itself. I was very disheartened having to tell 18 patients that next day that were on the schedule that we could not give them my typical medication, which is Regencov, or we give them Lilly. We happen to have Stravimide as well, but for me and my population of people that I service, and I'm privileged to be a physician for my patients, and my patients come from everywhere, by the way, guys. I have patients coming from West Palm Beach, from Colombia, you mentioned that, from Argentina, Governor, as well as patients from Mexico. And I always say to residents, you treat the patient and not the lab, right? So we have an acumen that we develop, hopefully we all develop a skill set of being able to know what our patients would benefit most likely from. For me, to take off the table two arsenals that have been extremely important was bothersome to me. And this is the first time I really felt that I had to speak up because I felt that my ability to take care of my patients was being interfered with. And again, I have no issues with all the other therapies that are out there, but again, this is a treatment. I started, by the way, guys, 2 years ago when I was the ER doc over in North Dakota. I'm licensed like 13 states, by the way. And in North Dakota, I discovered our first patient in Wilmington, North Dakota, Governor. And to see how things have evolved, so I went from the ER doc, still that, to doing testing and contact tracing, doing vaccines, as well as now doing, I could use monoclonal therapy as a therapeutic way of doing things. So I want to thank you, Governor, for your leadership. I know that I may not always agree with some of the things that necessarily go down, but I got to tell you, Governor, I thank you so much for taking lead on this.
Yep. Thank you. Okay, we have Scott Fortney. He's a realtor and has received the monoclonals very recently. So can you talk a little bit about yourself and your story?
Sure. Thank you so much, Governor. I appreciate being here. My name is Scott Fortney. I'm just a regular Joe, a realtor with Related ISG Group here in Miami. And it was a bit over a week ago, the weekend prior to this past weekend. I just didn't feel great. And then on Monday, I didn't feel great at all. And I went and I had a test in Sunny Isles. It's super easy to get. Had my test that night. It came back, you know, hit my cell phone or whatever. It said I'm positive for COVID. And I'm like, oh, dear Jesus, I don't need to do this. You know, it's a busy season for me. So I immediately, I knew about the antibody treatments that were available. And I immediately went online and I signed up. And I had the treatment scheduled for 10:15 the next day. And it was right here at MDC, actually. I drove over here from Sunny Isles. Got here, the appointment was 10:15. I got here at 10:10. By 10:35, I had already had the treatment, and I was doing the compulsory 45 an hour wait so that they made sure there were no side effects or what have you. And I went home and you know, went on about my day, which I didn't feel great. Went to bed. The next morning, I woke up and I'm like, wow, I feel better. You know, but anything was better than what I was feeling because the congestion in my sinuses was overbearing, and the headache and the sore throat, and I mean, it really was just, it was more than uncomfortable. Wednesday had an okay day, still a little tired. You know, I'm staying home, can't go anywhere. And literally Thursday morning I woke up and I'm like, I can breathe. I can literally breathe out of both sides of my nose. And it wasn't, when I say that I couldn't breathe prior to that, it wasn't how many of us, we get congested on one side, so we lay over and, you know, we can breathe out of that side, and then we roll back over and you can breathe out. I couldn't breathe out of my nose. And I literally was, that's probably why I had a sore throat. I just was breathing like that all night long. Literally Thursday morning I woke up and I could breathe. I haven't had any trouble breathing since then. I'm still a little tired. I don't have the stamina that I normally have, but I can say without fail, and I don't believe that it's psychosomatic. I mean, I felt so much better, had more energy, went back to my desk and started working. I just felt better all around. And I will say, I kind of have a control group I can share with you, is because the person that I live with, she got COVID as well. Elected not to have the monoclonal antibody treatments. She was tested positive the day following. Again, didn't have the treatments. To this day, she still feels terrible. Can't go to work, hasn't run a fever anymore, just literally feels terrible. And I'm here. So thank you so much. I'm grateful to be in the state of Florida, and I'm super grateful for your leadership and the ability to have this treatment, because not just for me, but I have a mother who's 86 years old. She's been vaccinated twice. She's been boosted. She's in Kentucky. They don't have this treatment there. And my biggest fear is she's going to get Omicron or whatever, and at 86 years old, she doesn't have any comorbidities other than being 86 years old, that it wouldn't, this option wouldn't be available to her. To me, it's not even disheartening, it's disgusting. If you have an option that's not harming people, give them a choice, let them make that choice with their physician. it's worked for me, and I'm very grateful. Thank you, sir.
And do you know whether you had Omicron or Delta? I guess, are you assuming it was Omicron?
I'm assuming it was Omicron. I do not know. No, sir.
Okay. All right, very good. Okay, now joining us on Zoom, we have Nancy and Frank Schlatter. So unfortunately, they were in the queue to have a monoclonal antibody treatment, I believe, yesterday. And they woke up to a message saying, you're out of luck. The Biden administration has canceled the treatments. And so I want them to be able to talk about, one, how they're doing and you know, what their feelings are about how that was handled. You guys want to take it away?
Yes, that's fine. I'll let Nancy start. She got sick first and would like her to say how she felt and dealt with it.
Yes. Well, it started actually a week ago today that I started feeling sick really very rapidly about 6 o'clock in the evening. And it was so rapid, it was scary, and just feeling horrible, and muscle aches and congestion and sore throat. And I just couldn't believe whatever was happening was so quickly that I felt so bad. And I took just, I think I called my doctor that night, and I think the next day she called. Thought maybe there was some therapeutics or something, and she said, no, there's nothing. And you're not sick enough, you know, I said, well, what about any MABs? And she says, well, you're not really sick enough for that. And I said, okay, although I don't know how she knew how sick I was. But the next morning, I tested myself. We had some home test, and I tested positive. And I just kept feeling worse and worse and running a little bit of a slight temperature. So I did all the things that you do, Theraflu and everything you could think of, and drinking and keeping hydrated and gargling. I'm kind of old-fashioned, but I gargle with some apple cider vinegar and warm water for the soreness, and that helped. And it was just, but I wasn't getting any better. And so I just felt horrible, and I didn't know what to do. And I know we had these monoclonal are available for people. And so I'll let Frank take it from there. And I'm still, today I actually, I think it started last night or this morning, that I don't have any taste or the smell right now. And but I'm better. The congestion is better with me. You know, that is better. So thank you for allowing me to talk about it. And thank you, Governor DeSantis, for providing this for those of us who feel like they may need it.
Sure. Frank?
Okay, great. I'd like to say a few words. We had a health plan. We were not vaccinated, but we worked on our immunity and our health, and we feel like we're fairly healthy for our age. And so our health plan was our option that we were holding on to was the MAB treatment. And when we decided that we needed to apply for the treatment, we weren't sure how sick we were going to get. So we signed up for it and were blindsided that the treatment was canceled. Fortunately for us, we've been able to recover, and we think we're getting over it. So we think we're going to be fine. But we were concerned about, okay, now what options do we have? What are we going to do next? Can we get antivirals or something like that, or do we just have to wait to get sick enough to go to the hospital? So that was our dilemma, and fortunately, our outcome is pretty good at this point. So we think we're fine, but we were really disappointed when there was short notice cancellation of the MAB treatment.
It was about 8:30.
And I think because the loss of taste, that very well may be Delta, right?
Yeah.
Yeah.
Can I?
For Delta, for sure.
So, you know, hopefully, you guys have turned the corner for good. I mean, it is encouraging to hear that. But right here is an example where, they may not have even had Omicron. It may very well have been Delta with those symptoms, and that's certainly how that presents clinically. So even more reason why you would want to just let them go ahead and do this. Now, so Scott, I just want to, you really believe that this made a positive impact for you getting the monoclonal?
100%.
Yeah.
And I was vaccinated.
Yep. And Dr. Shepke, just statewide, as we've been, working on it in this wave, I mean, can you say, and obviously you would need to do a control trial where you'd have a placebo group, a treatment group, but from what we've seen anecdotally around the state, there are patients that seem to have benefited from these treatments during this Omicron wave. Is that right?
Yes, Governor. Just as we heard from Dr. Reynolds and Dr. Farsi, I get reports from around the state from clinicians as we're doing our allocations to the monoclonals that they want more because they believe it's working for their patients. And to these folks' point, part of our allocation strategy is to make sure that every Floridian has a fair, equal chance to obtain this rarefied medical resource that they need for treatment. So our plan has been to distribute it based upon local and regional disease burden among providers that have the ability to give this. Hospitals, urgent care, primary care clinics, EMS, retail pharmacies, and of course the state sites, which really remove a lot of the red tape and burden for the average Floridian to get in there and get these monoclonals. And now, unfortunately, we don't have the supplies for that.
Governor, if you don't mind, I want to say hi, first of all, to my patients, maybe my patients, who knows. But they really hit on something that was very important. As a clinician, to hear what she's just said, losing taste and or smell is really very suggestive, highly suggestive of Delta. And it so happens that the Delta variant is the one that is really the most lethal at this time. And to not be able to treat, if she was my patient, I'm not sure how I would handle that, Governor, to be quite honest about it, because to me there's no doubt that she has most likely Delta. The thing that people do not talk about, when a patient gets the report like they did, positive and or negative, we have no idea what strand that they have, right? So for us, it's very important as clinicians to be able to discuss with the patient their symptomatology, their symptoms. And I recall going over to a person's home with my little, I'm an ER doc, so we go do things a little different, I guess, with our O2 sat monitor and blood pressure cuff and all the other things. And she had basically same thing that lady's just saying here, lost her touch, lost her taste, lost her smell. And at that time, we gave her Regeneron. And I got to tell you, the next day, she thought I was someone really special. I'm a regular guy. But it really definitely was, no question about it, Governor. It was the RegenCove, no question about it. And I want to tell you one other thing, and I'll stop. I've treated approximately 200 patients over the last 2 weeks in my practice in Coral Springs. And I can tell you that they range from ages of 20 up to 86, okay? When they come in, up until just recently that is, they tend to get, and they ask for RegenCove. If there is no reason why I would not want to give them that, if they, let's say they may have come into contact with someone, right? So I may do something a little different. But typically, they've all been getting either the Eli Lilly or specifically a RegenCove. And I can tell you, out of 200 patients that we've had a chance, I personally call the next day, they've had absolutely no problems with the medication, and they all are doing well. So I wish I could tell you guys something different than that, like maybe there's 2 or 3% of people that did not do well, but I'm telling you, they all did well, Governor. Thank you so much again.
Yep, go ahead.
If I may, Governor. Something that is personal, this is not proven by fact yet, but we're seeing when we've administered a very large dose of monoclonal over a very large amount of patients. And you heard of the long hauler syndrome.
Oh.
But there may be an association where we're giving monoclonal and we're seeing a diminished amount of long hauler. I don't have the data to back this up yet, as our data is collecting and is in a prospective manner. But we've seen significant patients who had long hauler and got reversed, happened to had COVID last year, got COVID again, got monoclonal, and resolved of their long hauler syndrome. We're not I think the FDA was a premature decision to remove it, and I hope that the FDA, with your help, Governor, it'll revert the decision.
Yeah, I mean, you just think about it. This stuff now is just sitting there. We don't have anywhere near enough of the sotrovimab.
No, we don't.
Some of these other things, I mean, you know, the FDA approved this Merck pill, and honestly, you know, you look at that data, yikes, yikes. And yet that is going and they're pushing. And yet this, they're somehow, you know, kind of going to war with. I wonder what's so special about this that they're doing this. So it's just sitting there. And you're hearing from people in real life who've this Omicron wave have been infected, got it, and did better. You hear from clinicians who are applying this to patients and having good results. Now, if you did a clinical trial, who knows what percentage the efficacy with Omicron? I don't know. I can't tell you that. But I can tell you when I see patients, when we have reports from our medical people saying patients have done well with this in this current Omicron cycle, I'm going to put weight into that and want to help other people. And I'm not just going to say, okay, because there was one lab-based study in vitro, that therefore we just have to turn a blind eye to what's actually happening in the real world. And so this is a lesson as to why you should not have the government controlling medication in this
100%.
country. I bought sotrovimab, but then the feds did an exclusive deal with them, so I can't do it. I would be using some of our resources to make sure this stuff was available. People can use it or not do it. It's their decision. And then, you know, some other states would probably do it differently. They'd continue to close schools. They'd force masks. They'd do different things, different approaches, and that's fine. But I would be able to do that and then to get it into the hands of the physicians and the clinics so that our citizens had access to this if this is something that they needed. And I think what the doctors both said in terms of like what the effects of this afterwards, the White House press secretary, you know, stands in front of that podium and lies through her teeth every single day, and usually about the state of Florida. The other day she said Florida hasn't done enough to get schools open. Are you kidding me? I remember them criticizing me when we did this almost 2 years ago. We were the only big state to have every school district open for in-person. And we did that way before Biden was even president. We didn't need the Biden stimulus money for that. We did it. We opened them. And yet they're saying Florida didn't do it. And you look right now, all the school closures across the country, you don't see that happening here like you do there. And yet that's what they do. And so recently she said that the monoclonals do not work, definitively do not work against Omicron, and they have really bad side effects. That's what she said. And that is not true based on what we've seen in the state of Florida. Obviously, human physiologies, anything you take, it's potentially, that's why we have the observation period where people are observed. We did the observation period for the vaccinations too, just to see, because these things happen. But the idea that somehow this has led to like massive adverse reactions is just a lie. And it is a lie designed to buttress politically a position that they have taken, which is just indefensible as a matter of policy, as a matter of basic decency for people. And so, yes, I understand up there, their whole rationale, you know, when they do those press conferences, to prop up the regime. I get it. But you can only lie so much. And you know what? People don't believe the lies because they understand how ridiculous it is. So we have people here who wanted the treatment. They're being denied because of the heavy-handed government. You know, we've been able to provide people to show that this is something, you know, that has been beneficial for people. And if you're going to rely on that one little, you know, lab study to say no one should even have access to it, even if they want it, it's just fundamentally wrong. And so, you know, we're going to keep fighting to provide options for people. If I can buy more of the sotrovimab, we will do that. Right now, we don't have the options to do that, unfortunately, because the federal government is controlling all this. But good Lord, I mean, this is just wrong. And to do it late at night on a Monday and leave people twisting in the wind and not being able to satisfy appointments that they had already been given, That's not the way you treat people. That's not what we want to see in the state of Florida. And so this is a big mistake, what they've done. Obviously, they've got a lot of other problems. I mean, let's just be honest. This has not been, a great show over the last year. But this is just unnecessary, and it was really done in a very heavy-handed and haphazard fashion. So I want to thank everyone for being here for this, and we're going to continue to do whatever we can to provide people with options and let them make their own decisions. And that's been our mantra from the beginning, empower you to make your decisions about all the stuff that's out there, but not to dictate that on your behalf. So thanks everyone for coming. Hey, Glenna. Good. How are you doing? So I think I'll let the doctor speak, but I mean, if you were to give something that the FDA has disapproved, you could lose your license.
Correct, 100%.
100% on that.
It's a federal offense to use a drug that is not approved by the FDA.
Because they like the Citroen, they don't give us enough. I mean, they don't give us enough to do. I would absolutely do. If they would replace the Regeneron and the Eli Lilly with Sotrovimab, we would absolutely keep the sites open 100%. But I can't have people come up and then not have the medication available for them. And they're just not giving us nearly enough. There's not nearly enough Sotrovimab out there. And it's interesting if you look at we have a couple that very well may have had Delta, even though Florida, is viewed as more Omicron. But there's states like Illinois that have 25% confirmed Delta, even right now. And so you're taking away the monoclonals from them. Now, I don't know that they've embraced treatments the way Florida has, but it isn't there's no more Delta in some of these other states either. And so, look, I mean, if that's the case, I mean, you could send that there, send us more Sotrovimab, what have you. But I would absolutely purchase more Sotrovimab to be able to keep the sites open. But the fact of the matter is, if they were to give the current medications, they could lose their license and face criminal prosecution. And clearly, people are not going to be willing to do that, and we understand that, and that's why this has been so difficult to see people not have access to something that we want them to have access to. Well, I think clearly the couple on Zoom would meet the emergency use authorization criteria. Do you guys want to talk about it? And my view has always been, we want to stay with that. We don't want to go beyond it. In point of fact, I mean, when people were coming, they were, doing it in terms of they didn't want to turn people away. Let's just put it that way. But I know that there are examples, particularly in this wave, when people will go who just do not need it and are not given it.
Right. I can speak again?
Yep.
Yeah. Speaking of the lady who is still on the Zoom, she had classic signs and symptoms of the Delta variant. She had loss of, and still does, from what I understand, of taste and smell. Headaches are usually pretty common with D variant also, Delta variant as well. So the bottom line is that I want to be able to pull out of my refrigerator, okay, what I think is going to be best for this patient. We do have Sotrovimab. We got a total of, I think, 8 so far this week. And I see typically about 50 patients every week without fail. If I had more Sotrovimab, I guess now, then we'd be able to treat more patients. But the governor is right. If we violate the FDA rules and regs and they pull the emergency use authorization, we could go to jail.
Yeah, go ahead, doctor.
I'd like to add something to this. It's not based just on these symptoms, right? Symptoms is what's difficult about this disease is you develop the symptoms, flu, cold, backache, body ache, and 3 to 5 days, you may be cured completely. What we don't know is that 5 days, who's going to turn to become a severe patient and die. And so the monoclonal, you must meet an indication, and those indications are based on the high risk, diabetes, high morbidity, hypertension, cancer patients, pregnant patients. We're not just giving monoclonal to anybody just for monoclonal. It's based, are you a high-risk patient and high risk of dying if you get severe COVID? Availability.
Yeah, I mean, I think, so if you look, say, like the Pfizer antiviral, you know, that is, quote, available in pharmacies, but there's not a lot of it that's been distributed. I mean, that's just the reality. And so how much of that would be available in terms of in different parts of the state? I mean, I think that that's an open question. That is not something that we're necessarily controlling, but it's all done through the pharmacies. But I do think it's really about your risk factors, and if you have modest symptoms, then that's actually when you want to do the monoclonal, because then the chance of you resolving is much higher. If you wait until the symptoms progress and become worse and you're on the cusp of hospitalization, that's when, you know, the monoclonal may not be as effective. Yes, ma'am. So let me just, before we do that, does anyone else have anything else on topic? Yes, ma'am.
I'm a member of.
And what data did they cite that was different from what we've talked about? Anything? You want to talk about that?
Yeah, yes, I understand that, and I appreciate that. And that's why I pointed out that we have conflicting scientific data. You have these peer-reviewed studies, which you just mentioned, which are on cell cultures, not on living human beings. That is the studies that you're referring to. I'm still unaware, and I've been searching for data, what we call clinical data, which is data on actual human beings. And then we have these case series, which are on real-life scenarios on actual living human beings that you just heard about. And these are certainly by no means unusual stories. We hear these from all over the place from folks who get this. So we've got two data points that neither one of them are conclusive, and they point in two different directions. And we certainly know that from both the fact that we've used this hundreds of thousands of times in Florida on Delta, the value that we had from both Regeneron and the Eli Lilly product against that particular strain. And as you hear, we still have likely cases of Delta within our state. So I think when you take the whole global picture of this, the fact that Florida is uniquely positioned as a high travel and tourist destination, so it's not just about our endemic various rates of the variants, that we may have influx of different variants constantly, and you hear the real world experience. I think at this point, when you've got limited options to treat, meaning that there's not enough treatment right now for everybody who wants treatment, and you're faced with making the decision of no treatment at all, or use a medication that you know worked in the past, you think it might work right now, but we're not sure based on the cell data, but we know it's benign and very well tolerated, then I would suggest that you continue the treatment until you have that clinical data that gives you the deciding answer, and which will give you the proof.
And there's been no clinical data, none. No clinical trial that's been peer-reviewed, that's gone through the process, no clinical data at all. And that's just the reality of the situation. And so I think what Dr. Shepke said is exactly right. When I see real-world examples of people benefiting from it, yes, I understand they're doing these things in the lab, and you should consider that. But man, does that mean not give anybody access? We don't think so. I would also just point out, the AMA, they've taken more ideological positions in recent years. They opposed, or they were not ever supportive, really, of monoclonal antibodies. I mean, when we rolled it out in August, I was criticized for doing it by a lot of people, and basically the medical establishment was saying, vaccinate and mask and social distance, and they didn't have much discussion about early treatment. And it's not just monoclonals. I mean, if you talk to our Surgeon General, he'll talk about fluvoxamide. He talks about other things, and we believe that those should be that stuff that people should be able to avail themselves with across the board. So monoclonals are one, but they're not the only one. Yes, sir. Well, first of all, yeah, go ahead.
I think if you look a little closely at the fine print there, they say they are predicted to not work versus Omicron, yet this must be confirmed in clinical studies is actually the way these things are written. And that's basically what we're saying, that while what occurs in cells may end up being what occurs in living human beings, it's not proof that it will. Many times it does match up, sometimes it doesn't match up. And so when we see these real world examples of the medication being used in humans, that's giving us a scientific signal that's opposite the scientific signal you expect in the cells, then we are in a bit of a quandary, and we really need the tiebreaker study, which is a clinical study.
And I don't think either company wants the EUAs revoked. I mean, that's the issue. If the EUAs aren't revoked, then it's a matter of, okay, is this something that's good? The doctors can recommend or not recommend. Different types of health departments can weigh in, whatever, and then people can make their own decisions. But to revoke the EUA is not something, particularly so abruptly, is not something that we wanted to do. And look, I mean, if there's Delta still available, so you clearly don't revoke the EUA. Everyone admits it was effective versus Delta. But I see these people that have benefited from it, and what are we supposed to do to that? Are we supposed to just say, oh well, they've done some lab work, and so yeah, you got better, but we're not going to let anyone people? I mean, we've got to just provide this. So let's let people make those own decisions. But clearly, revoking the EUA was not something that should have been happening. So okay, I got to run. Thank you guys. We appreciate you guys for coming in as well. Thanks so much. Thank you. Keep us posted as you guys do more stuff. Yeah.